Good morning, respected seniors, my colleagues. I'm Dr. Sandeep Sapkota, MD/MS Subspecialty First Year Resident at BPKMCH, and I'm going to discuss a multidisciplinary team discussion on a case of small cell cancer of lung with solitary brain mets. Starting with the case history, she is a 62-year female from Damoli, married Hindu. She presented with history of chest pain, central chest pain, as well as shortness of breath, for which she visited another tertiary center where lung mass was detected on CT scan and fluid biopsy was done, which came negative for malignancy. And the patient was discharged with follow-up plan for 3 months. This was the history of 1 year back. When the symptoms resolved on medication and the follow-up was defaulted by the patient. After 1 year, she presented with a complaint of headache, dizziness, slurring of speech, which was also often known, and the metastatic lesion was seen in the brain, for which she was referred to our center. She has been smoker for last 35 years with 12 pack years and no known comorbidities. On examination, general condition of patient during OPD presentation was fair and she was oriented with performance score of 2 and weight of 53 kg, height 154 cm. Bilateral on respiratory examination, bilateral normal vesicular breath sound without any added sounds were heard. And on CNS examination, grossly normal higher mental function with normal motor and sensory examination and cerebellar functions. During the hospital stay after the surgery, patient was disoriented and obtunded at times. There was 2 episodes of it. I'll talk about the surgery done later, but before that, the pre-op examination of this patient was normal, except that the sodium was low preoperatively, 132, and it has been low continuously, even in a post-operative period. And the histopathological examination report after the biopsy was suggestive of small cell carcinoma. So this was the first CT scan. This was done in some other center. You can see the tumor at the left side of hila, or which even looks like a mediastinal mass. So there's a round shaped tumor which is enhancing on the contrast with contrast. So the biopsy of this was negative, for which the patient was asked to follow up after 3 months, but they defaulted. So this is the tumor which was detected at the first visit. And she was defaulted for 1 year, and the MRI was done, after which she presented with headache and dizziness. The MRI was done with as showed us the about 4 mm use solitary lesion in the brain, temporoparietal 4 centimeters, sorry, 41 mm solitary lesion in the brain, which is enhancing, and there is a perilesional edema around the lesion site. And on MRI, it is indicative of the metastatic lesion from other site. So so there was an enhancing mass of 43 into 41 into 34 mm in right frontal, decentral and postcentral gyrus and right temporal lobe, with perilesional edema and 5 mm midline shift toward the left side. And after she presented on our center, we did the CT scan of the head, which showed the lesion of a same size with perilesional edema, and even the midline shift is there. So and the CT test was also done. We showed the primary tumor, which was enhancing, the round shaped tumor, which was enhancing, and there was a significant mediastinal lymphadenopathy as well. So CT report showed there is a multiple conglomerated nodal mass and anterior superior mediastinum, one measuring 36 into 26 mm, which was same mass with calcification, and the bilateral long field well normal according to the reports. So we did the VATS biopsy, thinking this as a CA lung with solitary brain mets, and On intraoperative finding, there was 4 by 4 centimeter hilar mass invading phrenic nerve and compressing the SVC. And the biopsy was taken from the mass, which came to be small cell carcinoma.
Compressing the innominate vein left or aortic or central? Innominate vein.
Innominate vein.
Left-sided.
In left side end. So now seeking for further treatment for this patient with lung mets, small cell carcinoma of the lung with solitary brain lesion. I've gone through some literatures, starting with a very small review. Lung cancer is divided into small cell carcinoma, which accounts for 85%, and small cell carcinoma, which accounts for 15%. And small cell carcinoma, it is usually associated with the risk factors like cigarette smoking and occupational exposure. Cigarette smoking was a significant risk factor in our case as well. And the global incidence, although is declining, the male to female ratio is now 1:1. So if we look at the small cell carcinoma itself, it's a highly aggressive neuroendocrine tumor, which usually originates from Kolchitsky cell in bronchial epithelium. It grows rapidly. It has early metastasis. It has a high proliferative index and often located centrally with the mediastinal lymphadenopathies. And small cell carcinoma itself, despite the TNM classification, like non-small cell carcinoma, it is classified as limited stage SCLC and extensive stage SCLC. And the prognosis, according to the stage, are the extensive stage as median survival of 8 to 13 months and limited stage as median survival of 16 to 22 months, with 5-year survival less than 20 in limited stage and less than 2% only in extensive stage. So most patients, they present with extensive disease at diagnosis because of the rapid tumor growth. This limited stage accounts for 1/3, and they initially respond well to the chemotherapy, platinum-based chemotherapy plus radiotherapy, followed by PCI. The prophylactic cranial irradiation is still debated. Now the MRI surveillance with stereotactic radiotherapy, if needed, has replaced the prophylactic cranial irradiation. But we are not going to talk about the limited stage as of now. The extensive stage accounts for 2/3 of the SCLC cases. Yeah, it has a worse prognosis, and the recent additions is the addition of the immunotherapy like PD-L1, anti-PD-L1 plus chemotherapy in the first line, and lurbinectedin as per NCCN in second line. And they have a median OS of 1 year with first line immunotherapy and 6 months with second line therapy. But what about the case with lesion, primary lesion in the lung and then a solitary mets? And what are the literatures regarding this? I'll discuss in the coming slides. So the main challenges with the small cell, extensive stage small cell, is they have a limited effective against with systemic therapy, and in most cases are poorly metastatic at diagnosis. And oligometastatic SCLC represent a small subset with limited number of mets, as with our case. And there is a role of stereotactic body radio ablation in oligometastatic extensive stage small cell carcinoma. And although the role is currently debated, but it is still in use. So now the SCLC with brain mets, 50% of patients, they develop brain mets during the course, and 20% will present with the brain mets. And early detection is increased due to the improved MRI access and screening, and it has a less than 5% survive beyond 2 years. So I've tried to review the management strategies in the small cell lung cancer. It's a review article from the Italy, presented, published in the Chest journal. So the traditional management was, if the tumor is, if there is a solitary mets without a mass effect, then traditional management was whole brain radiation therapy. It has been standard for symptomatic brain mets also, combined with the systemic therapy like chemotherapy or immunotherapy. Whereas now, due to the side effects of the WBRT, the significant neurocognitive side effect, the stereotactic radiosurgery is upcoming. And previously, the patients were historically excluded from SRT due to the poor survival expectation of the primary lesion itself and often multiple or diffuse mets. So now SRT is even being explored for up to 10 mets. It has shown promising result for local control with lower side effect, and increased availability and precision have made the neurocognitive side effect very lesser. There was a FIRE study, SCLC, for SCLC group, where international, it was a large study comparing SRT versus WBRT, and the key finding was median survival, overall survival was 6.5 months with SRT and 5.2 months with WBRT. So SRT may have a better control with the lesser side effect. And similarly with NCT 0339163 study, 100 patients with 1 to 3 brain mets were treated with SRT, and it was shown to be effective with reduced side effects. And also there is an ongoing trial, which other two ongoing prospective trial, which aims to enroll 56 patients comparing WBRT versus SRT in SCLC with 1 to 3 mets. Now discussing on the role of surgery, when do we indicate these patients for surgery? Now that we have discussed the traditional approach of WBRT and the recent SRT techniques, the surgery, especially in the small cell lung cancer, is very rarely indicated. If we see the guideline, they do not recommend that readily, but it is possible in highly selected patients, like the indications with the one with single accessible for surgery brain mets, which are more than 4 centimeters in size, with controlled or no extracranial disease, with good performance status. The surgery should obviously benefit patient rather than harm because of the performance status. And the tumor causing significant mass effect or life-threatening herniation risk, diagnostic uncertainty, example, need for biopsy in atypical presentation where the primary tumor is not found. And the post-op radiotherapy is generally indicated even after these surgeries. So these are the indications of the surgery, even in case of the small cell lung cancer. So if we, as already been said, if we see the guidelines and evidences thoroughly, the NCCN and ISMO, which we commonly follow for the thoracic tumors, they do not routinely recommend surgery for the brain mets in SCLC. The stereotactic radiotherapy and whole brain radiotherapy remains the preferred options due to better tolerability and ability to treat multiple lesions. The surgery may be offered in non-small cell lung cancer brain mets more frequently, as it has a good results rather than in small cell lung cancer. So there was a literature from Spain showing the management of oligometastatic non-small cell lung cancer patient. Even in the non-small cell lung cancer patient, this is a retrospective study with a single synchronous brain mets who underwent radical treatment for the primary tumor and the brain metastasis. Although they have shown that the overall survival is better if we do the treatment radically, but the surgery and whole brain radiation therapy am at a better overall survival versus the surgery alone. And later on, the many trials have shown that the stereotactic radiation surgery alone versus SRS plus WBRT, there was no difference in the overall survival. There was no benefit of the overall survival of the whole brain radiation therapy. So now the whole brain radiation therapy as a prophylactic or therapeutic measure has been replaced in various countries. So we can say that ours is a oligometastatic disease with a primary at lung and single mets at a brain, and they are the intermediate state between localized and widespread disease, widespread mets, and they may allow these kind of disease may allow for the long-term control or cure with aggressive local treatment, which was once considered as a stage 4 disease. They are further classified as a synchronous, metachronous, as the word suggests, and other subtypes like oligoprogression, oligorecurrence, and oligopersistence. The detailed diving is not possible in the lecture, in the discussion today. So synchronous oligometastatic disease, SABR plus thoracic primary tumor radiation therapy as a potential curative option as per the RTOG, as per many literatures. But there is more data needed, and there is no randomized SABR trial for small cell lung cancer patient specifically. So if we see the long-term patient survival in long-term survival in patients with the brain-only metastatic non-small cell lung cancer undergoing stereotactic radiosurgery, so we can see the aggressive treatment approach has a definite edge over the patient. So it improves the survival in brain-only metastatic non-small cell cancer. However, the data for small cell cancer are very limited. So another is the management of brain mets in lung cancer, evolving roles of radiation and systemic treatment in the ERAF targeted and immunotherapy. It highlights the role of radiotherapy plus the immunotherapy in the recent times, where the extended stage squamous cell lung cancer has been benefited from the atezolizumab and durvalumab, which used in combination with cisplatin plus etoposide. As these etoposide or even irinotecan, topotecan, they have intracranial activity as well, so they have the good overall survival if we treat the patients aggressively. So the same article has tried to highlight the non-small cell lung cancer and small cell lung cancer modality. So solitary brain mets, if there is a mass effect in non-small cell cancer, surgical resection is considered. If it is not if there is no mass effect, if there is a driver mutation, TKI alone has a very good result because they penetrate the CNS barrier. And TKI plus stereotactic radiosurgery is also being done in many centers. If there is no driver mutation, then radiosurgery is only the way to go. So in case of small cell lung cancer, if there is a known brain mets, if there is a limited intracranial disease, like single 1 to 3 mets, then stereotactic radiosurgery is still indicated for small cell lung cancer. If there is many number of metastases, the whole brain irradiation with 30 Gaussian fraction without limiting the radiation in the hippocampus is considered as the treatment modality. So in this from Zone et al., this literature from the Zone et al., they presented the case report. It's a case series rather than the case report. And in their case series, the patient presenting with oligometastatic lung cancer limited to brain were treated with both lung SBRT and brain ASARAS, and it achieved a good local control in all sites with improved overall survival. So the aggressive management is still warranted in these cases. So this is the small highlight in the NCCN guideline of the small cell lung cancer with brain mets. If the patient is asymptomatic, systemic therapy can be started before initiating the RT. If the patient is symptomatic of the brain lesion, brain RT before symptomatic therapy, unless immediate systemic therapy is indicated, and steroids can be initiated ASAP. And this is on further response assessment following primary treatment. The primary treatment has already been said. The response assessment is done, and adjuvant therapy, if it is a complete response or stable disease, adjuvant therapy of durvalumab or atezolizumab can be given, or even second line lurbinectedin can be added as per the NCCN. So NCCN, has already been said, doesn't recommend surgery for the small cell lung cancer metastatic, oligometastatic to brain. So these are the treatment approaches as per the guidelines. And as per the discussion to our patient, I think we should move with the aggressive treatment plan for our patient, because the literatures have definitely shown the good overall survival. So our patient has a solitary brain lesion with a mass effect, and the steroid has been started, and the further plan is yet to be seek from this multidisciplinary team discussion.
Thank you, Dr. Sandeep. I think Dr. Benju is here. She will highlight some of the neurosurgical points. So please come here just for a while. Sir, sir.
Good. Thank you, sir. Good morning, everyone. I'll be talking about management of brain mets from small cell carcinoma of lung. Dr. Sandeep has already talked about, so I'm going to skip this. And the metastases mostly occur, 85% occur in supratentorial, then 15% in the posterior fossa, and survival of patient with metastasis to posterior fossa is poorer than supratentorial. This also Dr. Sandeep has mentioned, and sometimes we are confused. Sometimes it's not always it's a metastasis. About 11% of patients with primary cancer have sometimes have glioma as a solitary lesion in brain as well. So these are the single solitary lesion and multiple lesion as diagnosed in MRI. And Dr. Sandeep told the definition of synchronous is diagnosed at the time of primary tumor, but also I think it's mentioned, I found somewhere, it's within 3 months thereafter also. If later than 3 months, then it's called metastasis. So these are the survival rate. If the most papers are on non-small cell lung cancer, and prognosis better than small cell lung cancer. Brain mets from non-small cell lung cancer is without treatment is 1 to 2 months, and with steroid only it's 2 to 3 months, and when it's given RT, then it's 3 to 6 months. So the median survival of patients undergoing surgery and both RT is 16 to 18 months. These are the MRI findings to differentiate metastasis from glioma, and this is the MRI pictures of metastatic lesion. In contrast image, this shows a regular and circular ring enhancing lesion. This is of glioma, where the ring enhancement is not regular, and this is a T2 image, and the metastatic shows high ratio of edema and lesion, and in glioma it's not lesion, perilesional edema is not so significant. And this is T2 FLAIR image. This shows this is of metastasis. The adjacent cortex beyond the ring enhancement, there is no thickening or abnormal tissue, but in glioma there shows thickening of adjacent cortex in the beyond the ring enhancing lesion. And for treatment of lung cancer with brain mets, surgical resection and maybe done with sodium fluorescent guided surgery or laser interstitial thermal treatment. And also after surgery, you can give WBRT or with radiation boost or with stereotactic radiosurgery and chemotherapy, targeted therapy. So I think this is for mostly for non-small cell lung cancer, but if small cell lung cancer also, we in solitary brain mets we can do surgery. It depends upon evaluation of prognostic factors, depends upon Karnofsky score. It should be more than 70%. Status of the primary tumor, age less than 65, and systemic metastasis, and physician's personal belief. And indication for surgery, I think this goes for also small cell lung cancer. People are not very large as in non-small cell, but some papers have come up with for small cell lung cancer to do surgery. So if we do is the solitary mets in non-eloquent areas, and if there are lesion up to 3 lesion or large lesion for more than 3 centimeter and life-threatening as like herniation, cystic lesion as radiotherapy does not do much better, we can do surgery. So advantage is to relief from tumor mass effect and associated neurological symptoms. And in about 30% there is unknown primary, but here it's not like this. And surgery is done to prolong the survival rate. So my conclusion is, even though it's a small cell lung cancer, and if patient is symptomatic with, as like above said, then we can do surgeries. So papers are there for advantage of surgery to do. Thank you, sir.
Thank you, Dr. Benju. So now let's start discussion, because why we discuss about this topic is quite often what happens. We physicians, I mean we surgeons, generally are very reluctant to treat this kind of people, this kind of patients. If somebody comes with a brain metastasis, we just think that it's stage 4 and the patient is not curable, and we recommend the patient, advise the patient's visitors that take home the patient is incurable. That's what the mindset of the most of the physicians. So with this discussion, maybe we'll learn something more and we can change the mindset of the physicians. So what she highlighted, Dr. Benjamin very well said, there is really the indication of surgery which we may not be aware of. So my few things that in our context, the patient was T4N21M1B, because she had got the unresectable lung cancer, T4 lesion, with multiple mediastinal lymphadenopathy fatty N2, and with the solitary brain metastasis M1B, stage 4 disease. So if you ask from the lung side, she's unresectable, so we don't attempt for the surgery from our side. But yes, we need to ask the neurosurgeon whether they are going to attempt for the surgery or not. Now the second question comes, in this particular patient, we discussed with the family members, what you wish. Do you wish for any intervention from the brain if you are advised for that? Or you wish to go for biopsy first and start the treatment? So they, in this particular case, they opted for the biopsy first for the lung tumor. Though there was the advice that go for the surgery. Now the question comes, now we know that this is the small cell lung cancer. Before, we didn't know whether this small cell or non-small cell. There was the chance that the patient might have the non-small cell lung cancer, and upfront brain surgery might have been beneficial for this patient. The first question comes, so if such kind of patient comes to us, how do we decide? In this exceptional case, we had the small cell lung cancer. There were the equal chances of having the non-small cell, even higher chance. So how will we decide that this is that case? So if such patient comes to us, then what's your opinion? Do we need to do the biopsy first of the more accessible, less invasive site, or go for the brain first? Because there were the indications that she has got the 40 mm lesion with the mass effect. There were the equal indication for the surgery of the brain as well. So what's your opinion? Would you like to have the first question, would you like to have the diagnosis established first, or go for some intervention from the brain side? यो सबभन्दा महत्त्वपूर्ण विषय नै हो पेसेन्टलाई हामी के आन्सर दिनु पर्यो नि हैन के गर्ने त थिङ्किङ द
cover from the incident. The congratulations on it for excellent presentation. I think this patient has symptom related to brain. There is no symptom related to brain. Yes, sorry, primary side. And first in the emergency, I think this patient will land in the emergency or something. First is the symptomatic management with Dexona and Mannitol. And if the patient, after patient stabilization, we can proceed for biopsy. In this case, if the accessible site is lung is accessible site, we can go for biopsy. Brain, if needed, it is radiological, so something else, it is not metastatic. You can go for biopsy from there also. And management part I'll cover after.
So, okay, so now you said the most accessible part has to be done first. So I think you are recommending for the biopsy from the lung, then go for the. Of course, in this particular patient, we have done the dexamethasone coverage, steroid therapy is started, and she recovered. I mean, she felt better afterwards. That's a good point. So that's okay. Now let's suppose if we are taking the patient for some of the surgery, neurosurgical interview, there is the chance, right? You think that there is the indication for surgery in this particular
because,
if we have not known this is the small cell lung cancer, right? So there is because there is the massive, the size of the tumor is quite big.
and non-eloquent,
Pardon?
and non-eloquent area.
Yeah.
And
So
mostly,
it is
and performance status of patient also good.
So I think the most important point is that we have to look at the performance ECOG or Karnofsky scale that was 70% in this particular patient. So CS stands good. Age-wise also she is less than 65 years of age. If she is more than 65 years older age, then there could be less likelihood. And third, the performance status. If it's performance status 3 or 4, we might be thinking otherwise. Right? But in such cases, we think about the life expectancy. The life expectancy is not good, then there may not be any benefit from doing some intervention or some therapeutic option, rather than simply symptomatic coverage with the steroids, etc. So I think that's clear. In particular, this patient could have been a good candidate for neurosurgical intervention as well. Right? So that's the first point. Now let's move forward. So may I request the medical team, Dr. Sajan. So this particular case has got the small cell lung cancer. So generally is set general for we surgeons, we think that most of the chemotherapeutic agents do not cross the blood-brain barriers. So is it true in this particular case or not?
Definitely, sir. The major concern in this case is the patient has a gross CNS aspects. Even though the neurosurgery team or radiotherapy will treat them, but what we do is that we try to use the drug that will cross the blood-brain barrier and that will treat the micrometastasis. That is not visible in the MRI or radiology. So all of the trials are going on, sir. That intrathecal chemotherapy is going on, but it has to only reached up to the clinical trial. Especially in case of non-small cell lung cancer, not in the small cell carcinoma, regarding the intrathecal chemotherapy. But whenever we choose the therapeutics, any biologics that cross the blood-brain barrier will be our first choice. Especially platinum, they are not that much permeable to the blood-brain barrier. But etoposide has a very good penetration to the blood-brain barrier. That's why the platinum and the etoposide is the first line as in the extension in any small cell lung cancer. And another science choice regarding the bevacizumab, that is also the trial is going. Also the trial is going on. Although it has a good blood-brain barrier, but the survival benefit is very modest. So if we see the expenditure done by the patient, especially in the binding costing molecule and in the platinum etoposide, the platinum and etoposide are till now it was gold standard before, and till now it is the mostly used drug in our cities. Excluding the immunotherapy. Immunotherapy has a good
Oh,
blood.
right now, before going to the image, you said that hydroxide is good and cisplatin is being combined. You mentioned about the intrathecal chemoagent also.
Yes.
So can we practice intrathecal? How much is it feasible in our setup?
Especially intrathecal chemotherapy are used in case of non-small cell lung cancer, sir, with brain mets. But and it has not come into our general standard textbook as well as in standard guidelines. These are only on phase 2 trial. Let's see what will happen in 1 to 2 years, sir. If it will come, definitely we can go for it, sir.
Yes, now regarding the immunotherapy.
Regarding the immunotherapy, sir, the majority of the concern in this case is patient has ECOG3, might be due to brain mets. If we treat the brain mets, then might be the patient ECOG purpose might improve, sir. But immunotherapy, especially if we see the Caspian trial and Empower trial, majority of patients that were included in this study were with ECOG 0 to 2, not 3. So 0 to 2 patients were quite able to tolerate even the toxicity of the immunotherapy, especially colitis, pneumonitis, this sort of thing. And whenever we see those patients in scattered guidelines, small with a limited number of the patients, whenever we see them, those patients with ECOG3, if we use immunotherapy in them, what they have shown that the number of the days of the hospitalization were very high, and the toxicity were very high, and even we're not able to improve the survival of the patient. That's why ECOG3 and below we do not routinely use for the immunotherapy.
So is it mandatory to do the testing, PD-L1 testing, or you can start without doing the testing?
Sorry. If small cell lung carcinoma has a mutation rate, so not for a PD-L1, by statement, what high number of mutation rate means that they have a tumor mutation burden is very high. So if we are talking about pembrolizumab, atezolizumab, and durvalumab, they work very good in case of tumor with high mutation burden, sir. No matter what the PD-L1 level might. So in our setting, in my thought, I don't think we need to go for PD-L1 testing, since we know by the biology of the disease that these are the tumor with very high mutation burden.
So what would be the expected cost of the durvalumab?
So durvalumab is not available in our setting, sir. Although even atezolizumab, not in our country. So we don't have much idea, sir, of what's the purpose.
So what kind of immunotherapy would you recommend in this particular patient?
Sir,
So what regime, for example, this is the patient, now you are going to treat her, so what kind of regime would you advise for?
sir, if patient is affordable and patient can afford, then we can go to the trial for PD-1 inhibitor like pembrolizumab and pembrolizumab with platinum and etoposide, sir.
So for that you need the testing, or you can
We
skip?
don't need a testing, sir.
Okay.
The biology of the disease
That's
speaks that this is the high mutation body. That's why.
Thank you, Dr. Saran. So now, Dr. Pradeep, he is our radiation oncologist. He is looking after the pulmonary malignancies and the GI, upper GI and colorectal malignancies. So may we ask the question? There was the literature review, and they suggested that yes, there is a role of stereotactic radiotherapy, SRS. Okay. So what's your opinion? So far, I don't know. I am not aware whether we have started in our center or not.
We have started in some palliative cases, in our cases, and because of the immunization device, max is not came yet with the high precise immobility, so that we can give in 10 minutes also. And in this case, particularly in this case, because of the youth lesion, which very original edema with midline shift, I doubt whether we can spare to camper or not in this case. We'll decide at the time of treatment because of the huge mass in the midline shift. In this case, we can give hypofractionation type of treatment similar to the sort like 40-day high fraction, 6 fraction. In this case, cyclic nucleus, and we can finish the treatment in 2 weeks time.
So now, is there some size criteria that defines whether a SRS is better or the whole brain?
It is 4 centimeter is marginal, what is this is with malignant lesion with lesional edema. In this case, we have to extend the margin further.
So you mean that SRS may be done in this case, and that can be done in outpatient also.
Yeah, we'll decide at the time of radiotherapy using the concrete, we can spare the hippocampal or not. At that time, we only know.
So that's good. So that's the point that
Actually, in proper SRS, SRT setup, we need precise immobilization all. Right now, we're not having those devices. So the conventional setup we're doing, we're actually taking more margin. If you have a proper SRS isostatic immobilization, then you can say sometimes 0 mm or 1 mm margin. Now we're taking like 2 mm or sometimes 3 mm. So with this, with the normal parenchyma included, we can expect some more adverse effects, but we're actually treating the tumor. So there was one cancer with brain mets earlier also. We treated with a single fraction, I think 21 grade. So it actually survived around 8 months. So we can do that. And if it is near some critical organs, then we can hypofraction it into 2 to 3. In SRS, we are treating with single fraction. In SRT, therapy, we are treating in 2 to 5 fractions. In 1 week, we can finish. And if required, we can treat in alternate days as well. So I think we can try that with SRT.
So are there some relative or absolute contraindications depending upon the location of the SOL in the brain that radiotherapy should be avoided?
No, actually, just like Dr. Pradeep said, during the planning, first of all, we have to, in this case, we have the CT simulation 1 CT scan.
No, I mean, not this case. There's some particular location for which the radiotherapy has to be condemned.
No, during the plan evaluation, we have to evaluate the percentage isolated coverage. Like for particular treatment, we want 98% of the dose coverage, we want to achieve that or not. And whether the structures like brainstem or cochlea are coming in those regions, and whether those organs they have exceeded their tolerance level. In that way, we can cancel the assessment if required, but otherwise, there's not such indication.
So now let's talk about our scenario. I mean, in our country, most of the people are poor. They come from the villages. So we're talking that the whole brain radiation should be avoided because of the loss of the neurocognitive function. There will be some dysfunction there, so that's why it should be avoided. So now let's think, not hypothetical, but actually what's happening in our country. People are coming from the villages. For them to know to do the higher function, like to do the business or to count the money, etc., may take 10 minutes or 10 seconds, 20 seconds extra because of the whole brain radiation. Or for those bankers who may require the SRS, for example, for them the high quality SRS has to be done. So most of the people in our country come from the poor background. So thinking that point of view, do you think the SRS, which is highly expensive, maybe I guess, than the whole brain radiation, is highly sophisticated, highly demanding? So do you think
in our setup, we have not made separate payment cost for gas.
Okay.
We are using that demand package.
That's great because the patient will be benefited.
According to the patient condition, we can convert this into the TDCRT or BMAT.
And then next question, how do you decide this patient has to be treated with the hypofractionation or the regular fraction for the brain metastasis?
According to the lesion site near to critical structure like brainstem, hippocampus, and other like organ of optic nerve and other nerve structure like cochlea, like that. Near to that structure, we have to do the hypofractionation, multiple fraction. The sinus, and in the peripheral region, the small region can give the SAT.
So, Dr. Benjamin, now coming back to you, do you still think that surgery has to be done in this particular case? Because he is of the small cell lung cancer. What is your opinion now? Coming to the point, to conclude with this patient, what do you think? Do you advise for the surgery now, or shall we start from radiation or chemotherapy?
Yes, sir. because the prognostic factors are good one for her.
So you advise for the surgery. Anything else? Do you agree with her, or you recommend in particular our case? To advise the small cell has been
After
proven.
dissection also, I think the post-op bed should be radiated.
Yes, that
And
is
when,
after.
the thing is that after dissection, the post-op bed will be actually more than the actual tumor lesion size. And while radiating, the more volume actually radiated. So it will be really more obstacles. And we have to, how long the patients will be survive. Basically, for SLS, SRT and all, generally, if we expect the patient to survive more than 4 months, then only we will try with SLS, SRT. Otherwise, conventional palliative, vulnerability and all those things. Or if the hippocampal is failing, that we can do. Because if it is like earlier question about the size, whether it is resected lesion or unresected lesion, whether the size. For example, if it is unresected one, if it is less than 1 centimeter of the PTV, which is the planning tumor volume, then we can give 24 grade, 1 to 2 centimeter, 2 to 3, or up to 4 centimeter. There is a criteria. So once we resect the tumor, the cavity will be bigger, and we have to control that, and we have to get few millimeter margins, and more area will be covered. And again, this case, it's not like curative, it's palliative.
Yeah, but the whole tumor, if not treated, the lifespan is only 1 to 2 months. The lifespan of the disease only is so short. We just want to extend the survival rate and without neurological complication.
I think yes. Any conclusion about
In this case, if we do the surgery, then we cannot completely resect the disease. We obviously have to give the radiation.
anyway radiation
Because
therapy
it
has
has
to
to
be
be
delivered, whatever kind of surgery is done.
We have to give radiation. This is to the patient party we have to take us. Whether there is surgery is reserved for later period also. If the with the radiation there is residual disease, in that case also we can surgery. Because in this case, patient is symptomatic and very regional edema, we have midline shift. You have to act fast in this case.
After radiotherapy given in this patient, how much tumor volume will reduce?
That we have to see for only. And even a
Very
patient
active
will
for
have
patient.
to be also-
It is very active for the patient. It is
Mass
not
effect after the radiotherapy, then the patient will have minutes.
No, we can, that we have to give the treatment and we have to observe volume.
That's
This is
why.
One angle answer when you have to talk basically to the patient party, because whatever treatment you give, it is going to increase by months. Single digit months, not that double digit.
This is
So you
a
have to be clear with the patient and let them decide.
This is a small cell cancer. This is a
Yes.
sensitive tumor. I think it will resolve.
Yeah, but size is
I
big.
don't know the whether it's
Talking
bigger rate
about very
or
honorary
bigger
parties,
cell.
although it might be a little bit debatable. So what we are expecting with our treatment is just survival for 9 to 12 months,
Yeah.
even with platinum.
Whatever you do, yes.
What we are dealing is the quality of the life
Quite.
and the quality of the life and how much patient have to expend on it. So if we talk in these patients, so by any means, if the symptom of the patient is controlled, we are quite good to give the chemotherapy, sir. And for the one big issue in this case, sir, if we are planning for the immunotherapy, this patient needs a long-term steroid. And steroid will dampen the effect of the immunotherapy. So in my view, sir, if we are seeing the quality of the life and the patient, I think surgery will help moderate.
More beat.
Yes. 65 years old with all the isolated treatments, I think hypothetically I think we can go for the surgery. How much benefit will the patient get?
That's good. So let's conclude. Thank you. But that was a good insight, because this kind of patient keep on coming to us, and we have to come across. So for today, for this case, let's decide it, because there is the debate ongoing. There is the controversy. So I think the safe landing will discuss all the things to the patient. But this is the benefit we advise for the surgery. The surgery, yes, faster recovery from the brain side will be there definitely. if you compare with the radiation or chemo, surgery will be the fast recovery, but the life expectancy will be in months later, only 1 month, 2 months, etc. Anyhow, less than 1 year will be survival result. So what you must do, only supportive care, only steroid treatment, or the radiation chemo, or the surgery followed by chemo radiation. So we'll discuss with the patient priority, then we will let you know. So anyway, thank you very much. It was good, I think. If residents, you have any question or something, I think that was quite educational for us also.
One
For surgeons, yeah.
just for the sake of my knowledge, I wanted to ask, after radiotherapy, how long does it take for the tumor mass to dissolve? I mean, stabilize? About 4 weeks. 4 weeks. So during that period, we have to treat the peri-lesional edema as well.
Yeah.
During the lysis.
After 2 to 3 weeks, the patient is comfortable, then we can start chemotherapy or the treatment modality.
I mean, its question is, do we need to cover up with the steroids? I think that was the question.
No, all the time. In the initial period, if the edema is resolved, then we can start radiotherapy, and in the initial 3-4 days, we can start steroid because radiation also is from edema. And after that, we can tap out the dose and stop.
So, does radiotherapy or SRS can overcome the risks that are associated with the surgery, or just like intraoperative risk, like after during the surgery, post-operative complications are also there. There might be hematoma, might sometimes need for exploration. Those are a few risks that are associated with surgery. And does similar risks are present if we go for stereotactic radiosurgery?
That's why what neurocognition, that one. Or if the guidelines talking about here, then we are getting extra, then can expect those things.
Margin जति धेरै ल त्यति cognitive functions
I think also that we can
Yeah.
NMDT is also.
Because during surgery, we don't go for total extent. We usually go for near total extent. So for SRS, there is specific margin that we can go, which are guided by the CT scan or MRI. And after surgery also, there will be some tumor left, definitely, because we cannot go for complete extent. There is chances, but there might be some tumor left, and we have to go for radiotherapy as well later on. So will these two modalities that have to go undergo the patient has to undergo treatment, and these two both outweigh the benefit of SRS?
With treatment?
Yeah,
Surgery
patient undergo surgery first, and then we have to go for radiotherapy as well. So does these two treatment modality outweigh the benefit of SRS only?
SRS is also radiotherapy.
No, I mean after SRS.
Single radiotherapy or multimodality treatment you want to ask?
Surgery plus RT or one day RT? Either we have to go SRS or SRT. Only if the tumor is multiple and huge tumor, then we have to go to RT. Only single modality of radiotherapy.
Okay, then thank you, and that's when it was